This is Mr. Nicholson. Mr. Nicholson was in a terrible accident at Walmart, an explosion. It blew debris and merchandise all into his belly. So he's come to the operating room to have all the debris removed so that he'll be able to go through TSA security again in the future. But don't worry about it. We have our best surgeon and we have our best robot on the job right now. You can see that the instruments are carefully removing all of this terrible debris from his body. And luckily, with this technology, he'll be able to go home in one or two days, whereas his father or grandfather would have had to go through this surgery and stay in the hospital for a week. So what kind of equipment is running this surgery? If we pan out, you can see that the surgery is actually being performed by a robot. But the robot is not independent. It's not an intelligent machine that knows how to do surgery. It's a machine that augments a human surgeon, that makes a human surgeon better at what she's already able to do. This robot, it comes in two pieces, and you can see that the surgeon sits at a console and operates the robot kind of the way that a pilot sits in a cockpit and flies an airplane. She has dedicated controls that allow her to manipulate and control anything that happens on this machine. And this machine was initially a research experiment from the Department of Defense. About late 1990s, the Department of Defense was looking for a way to do surgery where the surgeon sits at home, like in a Florida hospital, and these robot arms were positioned over a soldier on the battlefield. And they started inventing this technology so that that could happen, but it was in a time when the network, the computer network, really couldn't support that level of communication between the two pieces. So companies licensed this and turned it into a robot that could be used in any operating room. And so many of the advanced operating rooms here in Orlando are equipped with this robot, and many people going in for different kinds of surgery, whether they know it or not, are having surgery with this robot today. We know that here in our hospital in Celebration, there will probably be a dozen surgeries today using this robot. So how does this robot actually work? The surgeon sits and does surgery with two hands. And we can't give the surgeon more than two hands. They always come to the operation with two hands. But the robot itself has four hands. The robot brings four different instruments into the human body. And somehow, the surgeon can control all four of those instruments. You can see that Alyssa is manipulating two of the instruments right now. But there's two other instruments ready for her to take control of them. One of those is this camera right here. If you're going to do surgery with these inserted inside the human body, you need some kind of camera so you can see what's happening inside the body. Now, Alyssa can kick a switch over on her console, and she can take control of this camera and move it around. See? So that's Alyssa. That's not me. She has control of the two hands, but for just a few seconds, she can move her own camera around and position it so that she can see exactly what she wants to see inside the patient. She can also use another switch to change control from the right-hand instrument in this arm to the right-hand instrument in this arm. So she essentially becomes her own assistant. If there's a piece of tissue that's laying in the way of what she's trying to operate on, she might use this third arm to reach in and grab it and lift it out of the way and be her own assistant. And then once it's out of the way, she can move control back to this other arm and go back to doing surgery with her two main arms. So that's the robot makes her a better surgeon by giving her all of this capability that no one man or one woman could ever have on their own. They're kind of like Dr. Octopus in the Spider-Man series. They have control of more arms, but not with the neural interface that you see in Dr. Octopus. So let me show you some of the transitions that led us to the robotic surgery that we're doing today. So if you go back to the 1980s, in the 1980s, we started wishing that we could have less impact on the humans that come into surgery. And back then, everything was what you would call open surgery. So when you went in to have any kind of surgery inside of your abdomen, they would cut a doorway into your body so that they could get in and operate on the different organs or vessels or muscles that are causing you a problem. And even though the site of the surgery may be very small, like the size of a postage stamp or the size of half a sheet of paper, the surgeon needed to open a door this big because they were holding the instruments in their physical hand and had to get their hand inside of your body to do the surgery. So that was called open surgery, and for centuries, that was the way surgery was always done. A big scar, a big doorway that allows you to get your whole hand inside and gives you enough room so that you can see inside with your own eyes. But around the 1980s, we started popularizing a thing called minimally invasive surgery, or keyhole surgery. And in minimally invasive surgery, instead of making a doorway, we created small holes in the abdomen, and then we created these very basic instruments that were just the scissors or the graspers or the energy tools that a surgeon had been using attached to a long pole. And so through the hole, the surgeon would insert that instrument in and could reach inside your body and get to the site of the operation, but keep their big hands outside of your body. That was a nice advance because now you as the patient, instead of having a doorway cut in your abdomen, you could just have these little holes cut in your abdomen, which are easy to seal up and cause a much smaller scar. Well, as you can see, when I stick this instrument in, I can't see what's happening inside your body. So one of these holes, usually the largest one, was a hole where you inserted a camera. And the camera would go inside and bring an image out to you on a television screen. So instead of standing here and doing surgery and looking at the site of the surgery, my hands would reach inside and start operating on you, but my head and eyes would be looking at a computer monitor somewhere in the operating room. And so I could see what I was doing on the computer monitor, but because I'm going through these little holes and because the camera on this rod just brings out a flat image onto the screen, I was watching a movie that's kind of like a 2D movie. Now, if you've ever experienced trying to manipulate things in a 3D world while seeing it on a 2D screen, the sense of depth is lost. And so it's very difficult for the surgeon to look at the scene and understand how deep, how many inches further in a piece of tissue is that they want to grab. But they would practice over and over and over again, and over dozens or hundreds of surgeries, they would learn to interpret visually how deep something is. And they would also develop little techniques where they would gently slide in until they see the tip of the instrument touch the tissue and move it, and they go, okay, I know I'm there. And then from that position, they would start operating. So they could learn to operate in 2D, just like a person who loses one eye in a car accident can learn to live and walk around in the world with only 2D vision. Same kind of thing. So the surgeons are doing laparoscopic or minimally invasive surgery with these kinds of instruments, and they're cutting a few holes in the abdomen instead of opening a big door. This happens in the 1980s. Through the 80s, 90s, and then into the early 2000s, we start to experiment with advances in turning this into a more robust and a more high-tech operating environment. We'll get to that in just a second. So instead of having somebody operate with these scissor-like instruments, we want to give them something that's more high-tech to hold on to this instrument, and that's the robot. Now, before we talk about that, I want to talk about those holes that are in your belly. This is my friend, Mr. Teddy. Teddy's going into surgery, and Teddy's going to have some parts removed from his colon. Sorry, Teddy, does that make you sad? Yes, it does. Are you afraid of the surgery? Yes, I am. Well, that's okay. We're going to take good care of you. Dr. Tanaka has done this 5,000 times, and she never had a failure yet. Does that make you feel good? Yes, it does. Okay. So he's not worried at all now. Now, we're going to have to put you to sleep. And when we put you to sleep, we're going to cut a few small holes in your abdomen. It'll tickle. It won't hurt. We wish we could just cut one hole in Teddy's abdomen. it would be fantastic if we could put one hole in and everything could snake in through that one hole and start moving around like Dr. Octopus inside their abdomen, only much smaller. But right now, that kind of technology exists in the laboratory, but not so much in the operating room. You wait. In the next 10 years, by the time any of you finish medical school, you'll have exactly that. But today, let me talk about what you do have. So Teddy needs to have multiple instruments in his abdomen, and they need to come from different angles so you can get at the tissue you want to operate on. So Teddy would get an incision right here in the center, and we would slide a camera in there first. And that camera can look around and see what's inside of Teddy's abdomen. And then Teddy would get 3 small incisions for the 3 instruments that were on the robot. You remember those 3 arms that Alyssa was controlling? We would slide 3 of those instruments into Teddy's abdomen so we could operate. And we're still not finished. Now, we have an assistant, because when the robot's operating, the robot can't reach over to the table and pick up a suture with a needle attached to it. So an assistant has to pick that up and slide it through an assistance port into Teddy's abdomen. So now Teddy has a camera port, 3 instrument ports, and an assistant port at least, right? So that's 4, 5 at least. And in some surgeries, there might be a 6th hole where they would slide in a suction device that would suck up any fluids that were accumulating around the site of the operation. So Teddy is much happier with these 6 incisions, or 5 or 4, depending on the complexity of the surgery, than he would have been if we had to cut a big door in his abdomen. Teddy's stay in the hospital will be shortened because of these small incisions instead of the big door. When you cut a big door, you don't have a lot of leeway on what you cut. You just have to make an opening big enough for your hand to get in. So you end up cutting muscles and blood vessels and nerves along those long incisions. Whereas here with these, if you know where some of those large blood vessels are, you just move over so you don't hit the blood vessels. And because the incisions are so small, you end up hitting fewer nerves. So at the end of the surgery, when Teddy's recovering, he lost less blood because the incisions were smaller. He has less damage to his abdomen, and so he'll heal faster. And because all these holes were smaller than that big door, there's less area exposed to the outside air and to bacteria and infection materials that might get inside the body. So Teddy probably will be less likely to get an infection as a result of his surgery. That makes Teddy very happy. Teddy's very happy when that happens. So those are some of the advantages of minimally invasive surgery. And those are so important to patients and to the hospital that pretty much any surgery that can be made minimally invasive has been made minimally invasive, so that people have fewer scars, less blood loss, less pain. Also, Teddy has less pain because we cut fewer nerves. That all makes Teddy happier. Now, when we make robotic surgery, it's the same idea of making small incisions, but the big difference is that instead of me reaching inside of Teddy's body with these kind of crude scissors, we can have the robot hold on to the end of this and have a computer calculate how every movement should go. And so the robot can allow the instrument to move almost exactly like a real hand. We'll show you some of that with the real robot. Okay, stay here, Teddy. We'll be back. Okay, come over here to this box. This box trainer, it can show you kind of like what it's like to do surgery inside of an abdomen. You might want to look up at the monitor here for this. You can see that we have 4 instruments in the body, and if I slide one of these laparoscopic instruments in next to it, you can see that here's the laparoscopic instrument that's manually controlled. I can reach in, I can reach out. If I want to grab tissue, I can rotate the whole jaw around to the side, but you don't see me bending the wrist, because with this crude scissor control, there's just no way to bend that wrist effectively. And you can see that Dr. Tanaka's hand can move that thing around in almost any direction. Actually, the robot has more freedom of movement than the human wrist and hand do. because it's not limited by the joints and the bones. It can go a lot of different directions. So she can do a number of surgeries with this robot that are really difficult. They're not impossible with laparoscopic surgery. Surgeons can learn to do this. It just takes longer to learn how to do it. And it's a little more cumbersome. She can learn to do that much more quickly. And once she's proficient, I think she'll perform the surgery more quickly as well. Okay. So, Alyssa, why don't you show them how the instruments work and just do a little surgery on this turkey breast. We have a piece of turkey in here that's a rough equivalent of human tissue. It's got muscle, and it has fat, and it has skin. And with the instrument she has right now, you can see she can grasp the skin and lift it out of the way. She has a pair of scissors that allow her to cut the skin away from the muscle or to cut fat away from muscle to separate two different planes of tissue. Oh, and the one I told you before that the robot doesn't have the ability to take its hand out of here and reach over and pick up a piece of suture to do suturing with. So an assistant has to hand the person the suture like this. So I'm the assistant, and I slide this laparoscopic instrument in, and I'm carrying a suture for her to operate with. And so I hand it to her, and then I pull out. And so the surgeon would then have the needle and suture and would start working inside the body. And when she finishes with that, she needs to get rid of that needle and part of the suture. And that's when the assistant would come back and reach in and take it and pull it out, set it aside. The assistant might also take out small pieces of tissue. So if she cut out some lymph nodes or any fatty tissue that she didn't want to remain in the body, with her robot hands, she would hand it to my assistant hand, and I would pull it out and set it aside for later analysis or to be disposed of. So there she goes. So right now she's suturing an incision. She made the incision earlier, and she's suturing that with two hands, and parked off to the side because she doesn't need it is a third hand, which she can bring in when she does need it. Now, one of the tricky things that you can do with this robot, when you're suturing, you kind of want to push the needle through and then roll your wrist to push the needle around the incision and bring it out the other side. Watch this. There she goes, rolling. With laparoscopic instruments, that rolling motion can be really tricky. You can learn to do something approximating that, but it's not as natural as you would do it with your normal hands. And Alyssa's doing it pretty much the way she would be suturing with her own two hands. Now, one of these instruments also has energy attached to it. So she has the ability to cauterize this tissue. You can hear the beeping sounds. That means that she's stepping on the energy pedal, and it's sending electricity into the instrument. And that electricity can either cauterize a blood vessel and cause it to stop bleeding, or it can actually be used to cut tissue like it's a knife, like an electronic knife. Her energy right here is cauterizing or burning the tissue. Now, it's not enough energy that you could cook this so you could eat it. It's specifically made so it only cooks or burns the tissue in a very small area, because you want to have very, very precise control. Around this area, there might be nerves or blood vessels that you want to make sure do not get any energy. So that's why the burning effect is only exactly where she's touching it. So that's our turkey breast. You can see inside the body, there's 3 instruments there. The Da Vinci has about a dozen instruments available for surgery. And some of the most common are those scissors that are off on the right-hand side. We don't give the robotic surgeon an open scalpel blade. That's a little too wild to be moving around. So you put the scalpel in the form of scissors, so you actually have to reach in and grab something and close the scissors on it to cut it. You can also use an energy tool, so you can step on an energy pedal and send the right kind of energy in there, and that will cut the tissue. And then the third one is the needle drivers that are also on the right-hand side. The needle drivers are unique in that they are short, stubby, very strong fingers. So when you grab a hold of that needle and you try to push it through any kind of tissue that's very tough, that hand is strong enough to hold that needle firm and push it through that tissue. One of the demonstrations that we sometimes do with visitors here is we have 2 of those needle drivers, and we hand them that suture with the needle on it, and we ask them to hold it in their 2 human hands and try and break that suture. And it's roughly like trying to break a fishing line. You really can't do it. But then if you give it to somebody with 2 needle drivers, they can grasp that tissue and break it in half. They can also take the needle, which is a very strong piece of steel, and bend it backwards and straighten it out. So the robot really is much stronger than a human is. So those are some of the major instruments. There's another dozen or so that we're not using right now. Okay, so pan out. Let's see this whole robot. This robot is a very advanced piece of equipment. And as I said, it's in most of the large hospitals here in Orlando and in most of the large hospitals around the country. But this device that you're looking at here costs $1.8 million. So if I want to do surgery with it, I'm going to be very protective of this device, and I'm going to hold it in the operating room, and I'm going to try and do as many surgeries as possible so I can earn back that $1.8 million investment in this device. But if I need to train somebody on how to do surgery with this robot, you need to find a classroom where you can afford to pay $1.8 million for a single device. And just like your high school, if you look around the high school, you'll see that there's not any piece of equipment in the high school that costs $1.8 million that they're using to teach you math or physics or any kind of engineering or science. That's an unrealistic budget for education. So here at the Nicholson Center in Celebration, we do have these kinds of robots that are available to learn on, but not very many of them. So if we bring in a classroom full of people, we usually don't sit them down at the robot and start teaching them with this $1.8 million device. Instead, we start with this simulator over here. Follow me this way. So this device right here is a simulator of the Da Vinci robot. Robot costs $1.8 million. Simulator costs about $100,000, a little less than $100,000. It has many of the physical attributes and all the same controls as the robot. So I can sit a student down here, and especially somebody who's brand new, I can walk them through all their basic skills, teach them how to use the hand controls, teach them how all of the different foot controls work. There's 7 pedals down there that you have to learn how to use. And get them used to operating in a 3D environment and passing sutures and needles in, and get them used to each of the instruments on this simulator. So if I bring in a class of 10 people, I have 10 simulators here, and I can have them all sit at their dedicated simulator for an hour or 2 hours. And we can watch their basic skills improve on the simulator in a matter of hours, rather than having them queued up at the few robots we have, mostly watching other people use it and waiting their turn. So we find that students who come here and learn first with the simulator raise their skill level in a day-long class much faster than people who have the robot exclusively. So here at the Nicholson Center, we consider ourselves an education center because we're here to teach people to become better surgeons. And sometimes that involves the use of simulators, and sometimes it involves the use of real surgical equipment like this robot. So we structure our classes around lectures and videos of real surgery and the use of simulators and the use of real equipment. And we bring surgeons through the Nicholson Center every day. And by the end of the year, we usually bring in maybe 10,000 surgeons that will have a short class here. So that's robotic surgery, simulation, and a little bit about what we do at the Florida Hospital Nicholson Center in Celebration. So that's basically the introduction to the technology.